Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hi, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will discuss another recently published original science paper in the journal. The paper is titled T2-Weighted Lung Imaging Using a 0.55 Tesla MRI System. This paper comes to us from our colleagues at the National Institutes of Health in Bethesda, Maryland. The lead author is Dr. Adrian Campbell-Washburn, and the senior author is Dr. Marcus Chen. MR imaging excels over other imaging modalities at tissue characterization. However, compared to CT, lung MRI has made only a small splash in the clinical pulmonary imaging community. The reasons for this are many. Some limitations are related to the inherent lung architecture, such as the low proton density of lung tissue and the significant susceptibility gradient artifacts from numerous air tissue interfaces. Additional impediments include relatively lower scan spatial resolution, longer scan times, limited scanner availability, and higher costs. Our colleagues at the NIH have created a novel high-performance, low-field strength MRI system to overcome some of these difficulties in lung MR imaging. Specifically, the investigators of the featured paper used a prototype 0.55 Tesla magnet with a closed-bore superconducting magnet as well as contemporary hardware and software. The two principal advantages of the system are the improved field homogeneity and the lengthened T2 star time of lung tissue. Using this system, the investigators explored the utility of a respiratory-triggered, T2-weighted turbo spin echo sequence in identifying common lung abnormalities. In this prospective study, the investigators recruited 24 patients with a variety of lung pathologies to be imaged by both low-field MRI and by CT. The MR images were reviewed and scored by 3 radiologists, and the findings between MRI and CT were compared. How did MRI fare in identifying lung abnormalities? What is the potential clinical impact of high-performance low-field lung MRI? Well, I had the privilege of speaking with the study's lead author, Dr. Adrian Campbell-Washburn, to answer these questions and more. Let's jump into that conversation now. Hello, listeners, and welcome back. I am joined by Dr. Adrian Campbell-Washburn, the lead author of our featured paper for this episode. As a reminder, the title of the featured paper is T2-Weighted Lung Imaging Using a 0.55 Tesla MRI System. Adrian, thank you so much for joining us on the podcast.
Thank you very much for having me.
Adrian, why don't you start by telling us a bit about yourself? Where did you train? Where are you currently? And what are your academic areas of interest?
Sure. So I am a Canadian, but I've lived and trained in a few different places. I received my undergraduate degree in physics from the University of Western Ontario, and then moved to the UK for my PhD in medical physics from University College London. For my postdoc training, I moved to the National Institutes of Health, specifically the National Heart, Lung, and Blood Institute, which is in Bethesda, Maryland, and I've never left. I'm now a principal investigator in NHLBI's Division of Intramural Research. My research interests are really in developing new MRI technology, so specifically new acquisition strategies and new reconstruction methods for imaging the heart, imaging the lungs, and performing MRI-guided interventions. And over the last 3 years, my lab has been specifically interested in what we can do with a lower field MRI system that integrates contemporary hardware and software for these particular applications.
Excellent. And I think that dovetails nicely into your publication in the journal, which discusses T2 weighted low field strength lung MRI. However, before we jump into the paper itself, let's chat a little bit more about low field strength MR. What exactly does low field strength MR mean, and how can it overcome some of the difficulties with standard MR for the lung?
Well, when most people think of low field strength MRI, they think of an old MRI machine that provides really bad image quality. Most people who started MRI in the 80s and 90s were used to working on zero 0.5 Tesla systems. But the truth is that our technology has improved a lot in the intervening time. So this includes the hardware, meaning the magnetic field homogeneity, the gradients, the receiver arrays, and the software, meaning we have better pulse sequences and improved reconstructions. So I think it's important to say up front that for this paper, we're using what we call a high performance low field system, meaning that we took a contemporary clinical MRI system and ramped it down to a lower field so that we could keep the contemporary hardware and software elements of a modern MRI system. But in general, for lung imaging, the real advantage of going down to a lower magnetic field is the field homogeneity. So if we use a contemporary superconducting magnet at 0.55 T, that means that we have improved field homogeneity compared to 1.5 T. The absolute homogeneity is about linear with field strength. So in the lungs, where there's lots of air tissue interfaces that cause susceptibility gradients and rapid T2 star decay, this is a really big deal. So by improving the field homogeneity, we've reduced a lot of those extreme susceptibility gradients, meaning that we don't generate substantial artifacts in the lungs. There are also some other advantages of lower field strength that are a little bit outside the scope of this paper. One is that oxygen can be used really effectively as a T1 shortening contrast agent at lower field strength, and that could potentially allow us to investigate regional lung function without using hyperpolarized gas. So that's another thing that we're interested in at low field. And of course, when we go down to lower magnetic field strength, the system is inherently less expensive, making it more accessible potentially to more people. And so these are the reasons that we're really interested in the lower field strength, specifically for lung MRI.
Excellent. And I know that you and your laboratory have done quite a bit of proof of concept work in high performance low field lung MRI. Can we briefly review some of the most pertinent findings in relation to the paper we're going to discuss?
Yeah, so previously most MRI studies of the lung have been done at 1.5 T and 3 T. There are some previous studies on lower field strength using older generation systems or open magnets, but these don't really compare to ours because we have this high performance low field system. And so we've previously published individual case studies on things like COVID-19 and patients with lymphangioliomyomatosis or LAM, and showed the example image quality that we can get on the lower field strength system. We've also published technical papers describing that oxygen enhanced technique that I've described earlier. And we've started to use the system for combined cardiopulmonary imaging. And so we've also done studies where we're looking at cardiac imaging on the system and comparing it to clinical cardiac imaging. And so those are sort of in parallel to the lung imaging study that we're talking about today.
Perfect. I'm sure some of our listeners out there have standard 1.5 T magnets and standard body receive coils. Is it possible for them, including me at my institution, to attempt in the near future to perform high performance low field imaging of the lungs?
Unfortunately, you can't do it with a standard 1.5 T magnet. So many of the components of this system were modified to ramp it from 1.5 to 0.55 T. And we collaborated with Siemens to do this. So it's unfortunately not possible to take a standard 1.5 T system and operate it in this way. I will say that we were the first to have this particular system configuration, but now there are other researchers who have implemented the same system. Again, this was a big permanent modification to a system. And that Siemens now has a commercial 0.55 T system, which just received FDA clearance. And there are other vendors looking into similar configurations. So I do anticipate that there will be more availability of these systems soon, But if you wanted to do it tomorrow at your own institution, it's going to be a lot of work.
Excellent. Well, something to anticipate in the near future. Let's move from hardware more to pulse sequence now. In your particular publication, you investigated T2 weighting for tissue contrast. So why T2 weighting as opposed to other types of tissue contrast weighting?
It's a great question. I mean, the real advantage of MRI over CT is the ability to generate multiple contrasts. So in the long term, we want to be able to do T1 weighting, T2 weighting, diffusion weighting, to measure function, to measure physiology, and put that all together into a single package. We saw structural imaging as really step one in developing this comprehensive exam. And we started with T2 weighting for our structural imaging, because this is a fundamental image contrast that's used elsewhere in the body, like in the abdomen and in the brain. At higher field strengths, ultra short TE or UTE imaging is more commonly used to avoid T2 star decay, which gives T1 weighting or proton density weighting. And we instead opted for T2 weighting because it provided structural imaging that we anticipated would be similar to CT, and because it hasn't been explored much for lung imaging because of the difficulty with artifacts that I described earlier. But I will say that we started with T2 weighting, but we are working on other contrast weightings now. So something else to look forward to in the future.
And as a quick review, how is the T2 star time of the lung different at the lower field strength than at the 1.5 field strength, for example?
So at 1.5 T, T2 star is about 2 milliseconds. So that means our signal decays in about 2 milliseconds. At 0.55 T, we've measured it to be about 10 milliseconds. So we have more time to actually sample data before we lose our signal completely. And in the other extreme, if we look at 3T, it's more like 0.5 milliseconds.
Excellent. Okay. We've obviously spent this time discussing MRI of the lung, but many of our clinical imager listeners are very familiar with CT of the lung. CT is obviously very widely available. It's got relatively low radiation dose per scan. Why consider MRI of the lung altogether if we have CT that's available in relatively low dose?
So in my opinion, MRI will never replace CT for high resolution structural imaging. Other MRI researchers may think differently about this, but you're absolutely right that we can get CT images quickly with a low radiation dose, and I think that will continue to be the modality of choice. Perhaps with the exception of pediatric patients where radiation sparing is more important. But the thing that MRI offers is this flexibility in tissue contrast. So we can characterize tissue, measure physiology, understand the lung dynamics, and map that all back to the anatomy. And so I think it's this information-rich exam that's going to be pretty compelling as a diagnostic package. And that's where I think MRI will really make a meaningful clinical difference. So in this paper, we're showing structural imaging, but I think that's really just one piece of the puzzle that we're trying to build. It's an important piece, but I think that really when we talk about clinical translation, we're going to need all of the pieces of the puzzle for MRI to really make a difference in how we image and manage patients.
Gotcha. So definitely at present, the major advantage of exploring MRI for the lung is the ability to characterize different tissues. That said, is there any sacrifice that needs to be made for, say, spatial resolution with MR relative to CT?
Yes, so our CT protocol used 0.8 by 0.8 in plane resolution and 2 millimeter section thickness. And by comparison, our MRI protocol is 1.2 by 1.2 in plane and 6 millimeter slice thickness. So our MRI resolution is obviously lower, especially in that through slice direction with a 6 millimeter slice thickness. And this means that it's possible that we may miss small features or abnormalities in the lungs. And so we're working to improve our methods to improve resolution, both for T2 weighted imaging and other contrasts. But you're right that right now we are making a sacrifice in terms of spatial resolution.
Exciting nonetheless. I think we've spent a lot of time dwelling on the background. Let's get into your paper, your study, with particular focus on the design and the results right now. From what I understand, 24 patients with a variety of different lung diseases were included, of whom all of them got MRIs and chest CTs. From these 24 patients, there were 18 interpretable data sets. So why weren't all of those patient data included?
Yeah, that's right. There were 6 patients that we didn't perform interpretation and scoring on. There was one patient who had the rare disease lymphangioliomyomatosis, or LAM, which was included in this paper solely for the purposes of demonstration. It was not intended to be read or compared to CT, and that's because this is a really unique patient cohort that we see at the NIH, and it wasn't really suitable for the purposes of the study where we were trying to compare really common findings. The other 5 were excluded for technical reasons. Most notably, 4 patients were rejected because of respiratory motion in the images. And this is a respiratory trigger sequence based on the diaphragm position using a navigator. And that navigator is far from perfect. And so if respiratory rates changed over the course of the 10-minute MRI acquisition, we would end up with severe respiration artifacts in our images. And unfortunately, that led us to have to exclude 4 patients. And in the one additional patient, they were rejected because of a broken receiver array. So this was a fundamental hardware problem. And this is a problem working on a one-of-a-kind experimental system means that sometimes this happens and we need to fix a hardware component. And unfortunately, that happened for one of our patients.
Of course, and many of our imagers out there are certainly familiar with the caveats of using respiratory navigation. When our patients fall asleep in the magnet and start to get a little more Cheyne-Stokes, we start to lose the ability to get reasonable time of acquisition of data.
Exactly.
Very good. Well, with regards to those interpretable data sets, 3 radiologists evaluated them for both image quality as well as identification of lung pathologies. To review what those pathologies were, they were scattered nodules, tree and bud opacities, ground glass opacities, cavitation, bronchiectasis, consolidation, atelectasis or scarring, mucus plugging, and pleural effusions. So with which of those pathologies did MRI excel? With which did it perform the best?
Our main metric that we used to evaluate MRI and CT was the kappa score, and MRI had substantial or almost perfect agreement with CT for scattered solid nodules, for cavitation, for bronchiectasis, for consolidation, for mucus plug, and for pulmonary effusion. So many of the abnormalities that you listed previously. Basically, we found that MRI did a good job when the abnormalities were larger and when they had some impact on water content, because that's really what we're imaging with these T2 weighted images.
Okay. And in contrast, where did MRI not perform as well relative to CT?
We found it performed only moderately for the detection of tree and bud opacities and ground glass opacities, which are very subtle findings. And we suspect that this is because of the lower resolution of MRI that we talked about before, but also because our MRI images were acquired at expiration, whereas CT images were acquired at inspiration. And acquiring images at inspiration helps to emphasize these findings because the lung is expanded. So again, this is something that we are attentive to and working on for a future implementation of this sequence.
And for our listeners, if you haven't seen the images comparing the CT and the MR, and you're not familiar with what lung MR imaging can look like, I strongly encourage you to do so. It's for the layperson nearly indiscernible, the differences, and for the advanced readers, even still, it's readily identifiable, each one of these pathologies. I think Adrian's being a little modest when she's saying the correlation's only modest for some of these things. The image comparisons are quite impressive.
Thank you for that.
Of course, let's move to the implication of these findings. I know that you're a physicist, but if you could opine on what you think the main clinical indications for a lung MR could be in clinical practice.
Yeah, so as you said, I'm a physicist, so I'm not a pulmonologist or a radiologist, but from my perspective, if we're talking about structural lung imaging alone, I think that pediatric applications are going to be important where MRI was likely to have more clinical adoption. I also think that there's a role for this MRI system in assessing and monitoring some of those features that we talked about earlier. As you said, the images are almost indistinguishable for most of the features, except for perhaps some of the smaller ones. And so I can see MRI playing a role in the assessment of those features. In the longer term, once we've refined our ability to perform more comprehensive exams, like we talked about earlier, then I see a role of MRI to assess characterization of lung nodules, or to assess pulmonary fibrosis, or to look at regional ventilation and perfusion and COPD and asthma and other diseases. And I foresee a really broad clinical adoption for those particular applications. although there have been other research studies that have assessed the added value of MRI for some of these tissue characterization type applications, low field is still a really important step. Because of the reduced artifacts in the images, we can do a much better job of structural imaging, and we anticipate we can do a better job of putting together this comprehensive package.
Okay, great. So I kind of think I know the answer to this already, but based on these data we just reviewed, as well as your own personal experience, do you think that high performance low field MR is ready for clinical prime time? And if not, what would you like to see before it gets rolled out clinically?
So the short answer is yes. I think that the T2 weighted imaging is ready for prime time, but with the caveat that it will get better over time. I'm a physicist, and it's my job to see how the technology can get better and continue to make improvements. I would still like to see some additional experience gained with this technique. This is a pretty small study that we're talking about. And I think that as we get more experience with it, we will get more familiar with how to use these images. So although I think it's ready for prime time, I still think we do need some more experience before we'd be comfortable using it broadly clinically. For the other techniques, I think some are ready for prime time already, like ultra-short TE imaging, but others aren't, like regional ventilation and perfusion imaging, as we've talked about before.
Brilliant. So what future work do you have planned in the field of high performance low field MR?
We have so much planned. We are continuing to optimize and validate and improve a lot of the methods that we've discussed when it comes to tissue characterization and regional functional imaging, and hopefully to provide a really comprehensive package for lung imaging. And we're also really interested in combining cardiopulmonary imaging. The cardiac MRI on 0.55T is really exceptional. And so the ability to image the heart and the lung in the same setting, I think is going to be really powerful. So there's still a lot planned for the system. We have a lot of interesting development to do and a lot of clinical evaluation planned in our future.
Adrienne, this has been fantastic. Do you have any final comments before we close?
I guess I just wanted to add that I think it's clear already, but I anticipate really big things for low field lung MRI over the next several years, especially as more sites start to work on this topic and these systems become more widely available. In my opinion, it's really the right time to explore this area, given the maturity of the computational techniques that are available to us and the cost of computational power compared to 10 years ago. I think we can really push the limits of how we image with this particular system. And I'm a big proponent of open collaboration and sharing, so I'm really excited to work with other sites as they get started on low field lung MRI.
Excellent. Adrienne, thank you so much for giving us your time and expertise here on the podcast. And thank you for your contribution to the journal and to the science as a whole.
Thank you.
And to our listeners out there, thank you all for tuning in. If you like what you hear from us on the Radiology Cardiothoracic Imaging podcast, please rate, review, and subscribe. We will see you next time.